All right. Good afternoon, everyone. Thank you so much for joining us for another session of the EIM Research Learning Collaborative. This is our second in a two-part series on looking at integrating physical activity into low resource settings. And today's talk is going to be is titled EIM in the Real World, Community Engaged Research on an Urban Exercise Prescription Program for Under-Resourced Women. If you've been on these webinars before, you know I like to start off with a little bit of background on exercise as medicine. Just make sure we're all coming from the same place and understanding what our mission and vision is. So here's our vision. It's to make physical activity assessment and promotion a standard in clinical care, connecting healthcare and the patients with evidence-based physical activity resources for people everywhere of all abilities. And I think this two-part series is really focusing on that last part, for people everywhere and of all abilities. So with the EIM Research Learning Collaborative, we really, about a year and a half ago when we started, our goal was, how can we bring people together, clinicians, researchers, practitioners, people who have frontline experience, and really accelerate research around the EIM initiative. Okay. We want to really focus more on examining the dissemination, adoption, and adaptation of best practices for integrating physical activity into diverse health systems. So we're not focusing on as much as what are the benefits of physical activity, but more so how do we get physical activity integrated into health systems. All right, so we're really trying to increase capacity and connectivity of research scientists doing this work. There's not enough research out there. There's a lot of projects. There's a lot of enthusiasm, but we want and we need more research. So what are we doing with EIM? We're really looking at this as a systems approach. We're trying to change and impact and then measure the structural and policy changes that are affecting standards in healthcare and how we connect patients to those physical activity resources. We want to integrate that physical activity assessment, and we did a two-part series on that. That's on our website, and refer people to these pathways using the electronic health records, and then really building that bridge of trust to community for physical activity resources for patients. And again, these are all areas that are ripe for research, and that's what we're trying to do is build that capacity for people to get involved in doing this. So our whole exercise as medicine profile, really starting in that healthcare setting, it starts with that routine physical activity assessment and screening. We see a lot of health systems doing this, which is really great. Measuring it, there's articles out there. We have a lot of articles on brief advice. That was the way people did things, and we were examining in the 80s and 90s, providing that counseling, and more so now that physical activity prescription. And then for me, what I find of great interest is referring patients to those physical activity resources. And this kind of follows after that expert model, which has been used so much, especially in substance use settings. So today, our speaker is Dr. Sarah Camhi. She's an associate professor in the Department of Kinesiology at the University of San Francisco. So there's a PhD in kinesiology from Maryland. And you can see what her work here is really doing exactly what we're thinking, looking at the barriers and challenges related to participating in these exercise prescription programs for healthcare providers in underserved populations. And I think today she's going to be speaking about this one article that was recently published and really talking about the challenges and barriers to conducting this research at her former institution. So I believe that's it. And I will stop sharing my screen. And Dr. Camhi, it's all you, please.
Thank you. Can you all hear me okay? I'm going to share my screen. Hopefully you can see my slides. Let me put it in presentation mode and get us started. So as Mark mentioned, my focus really is on the methods of how I did this research. So if you're interested in the results, I definitely encourage you to look at the publication, but I wanted to give you a sense of what went right, what went wrong, what would I change as a way to sort of help other people who are in this space, and maybe it might encourage you to do your own research. So just a little bit of an outline for what I'm going to talk about today. Just a very brief background on health disparities and chronic disease, just to set the stage. I'm going to talk very briefly about physical activity strategies in the healthcare setting and a little bit more about exercise as medicine. And then the bulk of my time will be talking about the methods for a particular project I did called PEP, or Project Exercise Prescription. I'm going to spend a lot of time talking about how we prepared to do the project, a little bit about recruitment, the data collection, and then I'm going to finish up talking about the process of manuscript writing. And there'll be about 15 to 20 minutes at the end for questions or comments. So just to sort of set everyone on the same stage, we're all familiar with health disparities and chronic disease. My particular expertise is in obesity and cardiovascular disease, so I always like to sort of position, my perspective for all of you. Obesity is increasing in the US, and we expect within the next 10 years that 40 to 50% will be obese. We know that obese adults are more likely to have abnormal cardiovascular risk factors, and this makes those particular people at an increased risk for mortality and morbidity. Black adults in particular have increased risk for both cardiovascular disease and obesity, and Black women have even higher increased risks when compared to not only men, but their white women counterparts. The good news is that physical activity can improve both obesity and cardiovascular disease, but the challenge is that most of the US population does not meet the physical activity guidelines for either aerobic and strength training. And Black women in particular have the lowest physical activity levels of all of the race, gender, sex groups. So Dr. Salas, who's the Exercises Medicine Global Chairman, once said, "What if there was one prescription that could prevent and treat dozens of diseases such as diabetes, hypertension, and obesity? Would you prescribe it to your patients?" A hypothetical question. We all know the answer. Of course we would. What is this prescription? Well, it's physical activity. So physical activity promotion in the healthcare setting is a really important strategy, and that's what I'll be focusing on today. So the healthcare office is the most common place to receive healthcare services, and healthcare providers themselves have been shown to positively influence physical activity. And for this reason, the American College of Sports Medicine began the Exercises Medicine Initiative way back in 2007. Now, Mark already talked a bit about this, but I'll be focusing on the community-based extension of healthcare for at-risk population groups to provide a cost-effective approach while providing a high level of care and support. So it's that community-based extension for physical activity resources that I will be focusing on. And Mark just showed this slide, but just as a reminder, there's sort of three aspects to exercises medicine: routine screening and assessment, brief advice and counseling, and then referring a patient to physical activity resources. So what do we know about exercise prescription use? Well, do they sign up for it? About 77% of participants who receive an exercise prescription actually participate in the program. So that leaves a bit of room on the table to make improvements. Do they attend? So you'll see here there's quite a range in whether they actually attend and complete the program. That's because some exercise prescriptions might be a one-day workshop, some might be a 6 or 8 week program. And so because of that reason, there's quite a range in whether they complete it. But again, a lot of room on the table to make improvements there. The reasons that people talk about why they don't use their exercise prescriptions is lack of self-efficacy, lack of social support, and lack of access to exercise facilities. So in doing my research many years ago, I noticed that there were some gaps in the literature. There was extensive research that was done in the UK and Europe, but it's important to realize that the infrastructure in Europe and the UK are different. The reimbursement strategies on how we can get paid for these services are different. And so a lot of the early research in exercises medicine wasn't necessarily applicable to the US healthcare system. Luckily, that's changed in recent years, but when I started this research, that was definitely a gap. There's also limited research specifically in Black and African American populations, which, as I mentioned, is a particular population that is more at risk for chronic disease. And I noticed that there was limited research that happened in urban communities. A lot of the research was in suburban settings. So I want to introduce you to one of my community partners named HealthWorks Community Fitness. It is a local urban community wellness center to the University of Massachusetts, Boston. It is a nonprofit women's only wellness facility, and it was located in Dorchester, Massachusetts. So I want to tell you a little bit about Dorchester just to sort of set the stage. This is a map of Boston. So like here's downtown Boston. Here's where the Red Sox play in case you're interested in sports. Here's where my university is, University of Massachusetts, Boston, located on this peninsula. And this yellow census tract here is Dorchester. So you can see it's south of the city, and it's bordered by the ocean here. A little bit about Dorchester's community and the participants in the community. You can see the heading of this particular figure is Dorchester's Hispanic population has been growing significantly. So from 1970 to 2020, the gray is the Hispanic population. You can see it's been increasing. The white population in the most recent data is about half what Boston's average is, and the Black or African-American population is much higher than Boston's average. So that just gives you a sense of who is in this community. The other thing about Dorchester is that it has the highest rates of chronic disease of any other neighborhoods that are in the Boston area. So higher prevalence of asthma, diabetes, hypertension, and obesity than the rest of the cities nearby. Here's some information on income and education. So just to give you context, the United States averages are here, Massachusetts, Boston, and here's Dorchester. You can see that for those that received less than a high school education as the highest level, the highest percent is in Dorchester, and the lowest median income is also in Dorchester. So I had been partnering with the wellness facility, HealthWorks Community Fitness, for several years, and we were doing community engaged teaching and service. So I sort of point to these two areas of this figure. My exercise science students from University of Massachusetts, Boston were volunteering for programming that was happening at the wellness center. And one of the programs that we were supporting was an exercise prescription program. So the HealthWorks Community Fitness actually was partnering with local community health centers and doing their prescription program, which began in 2008. They partnered with many different health centers around Boston. One of them was 5 minutes walk down the street called Codman Square Health Center. And any patient who had a comorbidity listed here was eligible to get an exercise prescription, which provided them free membership and access to the facility. So this is a little bit about how their exercise prescription program worked. So community health centers in and around Boston identified patients with risk factors and gave them exercise prescription and referrals. And then that patient actually walked a piece of paper, that exercise prescription, over to the wellness facility. And the wellness facility granted them access for free for 1 to 3 months. So that was sort of the model of their exercise prescription program. As I mentioned, they started this in 2008. And so in 2014, they published a paper and showed that 40% of the people who got an exercise prescription actually used it, and 10% attended for the recommended amount of time. So those percentages are way lower than the averages I presented before, just to sort of show you that there's a great program, but a missed opportunity. And so in talking with my community partner, we really wanted to dig deep into why were some people using it and why were some people not using the prescription program. And we wanted to do that from the patient or the wellness facility member's perspective. So we had been doing teaching and service, and we sort of wanted to add this research component in, which we had never done with this community partner before. And that meant doing a community engaged research methodology. So in doing this process, you sort of listen to what the community partner has to say, what their concerns are. You partner together and decide on, engaging in this project. You design the methods together and figure out how to reach all the people. And then you guide the community partner through the process as the researcher from the university. You guide them through, help them to collect the data and process the data and interpret the data. So my first challenge in doing this research was, I have a PhD in kinesiology. I'm a physical activity epidemiologist. I have training in public health methodologies, but I had never done community engaged work before. And here I was, just sort of naturally, it was happening in front of me, and I had to figure out how to do this without necessarily doing it before. So my first solution was, well, I need to get training and I need to find mentors. And I was really lucky because I was part of the University of Massachusetts system, and they have a special program called Community Research Innovative Scholars Program, or CRISP, that's open to any researcher in the UMass system. And it is a 12-month group-based mentoring program. So I automatically got mentors who were experts in the field. They gave me feedback on my design, gave me ideas about how to sort of position what we were doing. And so that was a really great way to get training in something that I hadn't really engaged or embarked on before. So it's important to know where to start, because this research, as a university person who is engaged in this research, we're outsiders looking into a group that had been existing for a long time. And we didn't know all the ins and outs of everything because, again, our perspective was from the outside. So before we actually went to recruit the patient and members, which were the people that we wanted to focus on, we needed to really understand the process from the inside out. So we needed to know how were the healthcare providers referring, what was the sign-up process like, how were the patients oriented to the facility, and then what did the wellness facility actually have and what did they offer? So we needed to look at a whole lot of different perspectives: the healthcare providers, the wellness center staff, and the community healthcare center administration. So we started by learning from our key informants and our stakeholders, our partners, and we interviewed all of these particular perspectives in order to gain a better understanding of what our methods should be, what questions we needed to be asking, what information everybody wanted to learn. And so that was a very long process that took a couple of months. And it really was preparation in order to do the research. So it wasn't even the research itself, it was the preparation for the research. So I thought I'd share with you a little bit about what we learned from those interviews and how that positioned us to sort of understand how to move forward. So one of the things about race and ethnicity in Boston is that it's truly unique. So this is a map of top 10 countries of birth for foreign-born population. Here's Dorchester again. And you can see that quite a few people are born in other countries. And so the terminology that you use when you're trying to recruit special populations is really important. If you're not born in America, you're not going to identify as being American. And so the word African American didn't resonate with this particular population or in Boston in general. So that was something I learned very early on. I thought I was using the correct terminology when I was talking to everyone and saying African American, and I was quickly corrected that Black is more inclusive, and that's what I should be using. And so that was really important because I wanted to make sure that I was capturing the population that we were serving. And so that was a quick change that I had to do for all the recruitment materials and making sure that I said the right thing. The other thing that we learned was that there was about a 50% no-show rate for community health center appointments that were related to health. So if they had a nutrition consultant or a mental health appointment, it was about 50% no-show rate, which is high. And so we needed to know that up front because they weren't showing up for their in-person appointments. Now, all of this research occurred pre-COVID. So the telehealth and e-health opportunities were not necessarily happening. Everything was in person. And we realized that in-person visits were just not going to make sense. And so we knew that we needed to meet the women from the wellness facility where they were and either be online or over the phone to encourage participation. In talking to a lot of the staff, we found out that a lot of the women didn't have internet access or computers at home. And so that really led us to realize that we needed to include physical mail as part of the recruitment, which seems very old-fashioned in this digital age, but that was, a means that was really important. And also that if they didn't have internet access or a computer at home, they might be accessing things that are meant to be on a computer screen on their phone screen. And so we realized that doing things verbally, talking to them over the phone was going to be the best method. The other thing that we learned is that appointment times are rather fluid in these situations. So if someone was signed up for a personal training, a cooking class, something at the wellness center, that they tended to start 10 to 15 minutes late because they just were waiting for people to kind of come. And so it was really important, I'm working with research assistants. They have classes and other things that are going on. And so we had to make our windows of time to collect this data from these women to be relatively wide, so that if there was a late, someone who came late, it didn't mean rescheduling and we could still do the whole appointment. We also learned the process of doing lots of different reminders a couple days before, a couple hours before, to try and help everyone be on time. So the next step in our process was to sort of nail down what we wanted to do for methods. We decided that to really get at what information we wanted, we needed to combine a mixed methods approach. So combining quantitative and qualitative information in order to really capture what was going on in this particular population. And so this sort of brought me to my next challenge. Again, my training's in kinesiology. I do have public health methodologies, but I am a quantitative researcher. And so I'm used to patterns and numbers and statistics for everything. And qualitative methods and mixed methods was not something that I necessarily was well versed in. And so in order to sort of make sure that I understood, the methods that we were using, I actually, I'm at a university. There's lots of resources at the university. So I audited a course on my home campus on qualitative research. The professor of that class was able to give me feedback on my research design and became a mentor to me for this particular research. And also I met graduate students in the course that I was taking where qualitative research is part of their repertoire. And I hired them as my research assistants to help with the transcribing and the coding of the interviews. So just by making connections on my own campus, I was able to sort of overcome some of the limitations that I had in my own expertise. Not only did I try to learn some more information about the methods, but I created a giant team of experts who had these expertise in mixed methods and qualitative research, also in recruiting from under-resourced populations. I had a big team of graduate students that I was working with, some from my own department of exercise science, but as I mentioned, I also partnered with graduate students in sociology who helped me with the qualitative analysis. So any researcher knows that you should always have a theoretical model to guide your research and provide that foundation. And so we chose the socio-ecological model as a way to really understand the barriers and facilitators at an individual, interpersonal, and environmental level. And this laundry list here is some of the variables that came out in conversations with my stakeholders about what they were interested in sort of exploring in this research. So as I mentioned, the name of this project was PEP, Project Exercise Prescription. And so, that was the start of sort of realizing how we wanted to do the project. We sort of realized there were two sets of people that we were interested in targeting for our recruitment. One was I'm calling them responders. So responders are the people who got an exercise prescription and went to the wellness center and signed up. But then there's also non-responders. Those are people who got the exercise prescription, but then didn't do anything with it. These people have very different experiences. And so we wanted to make sure to capture both parties in this research. So here's a little bit about our flow chart for kind of recruitment. So people got an exercise prescription from their healthcare provider, and then we divided them up into two groups, non-responders and responders, those who activated and those who didn't. Everybody went through a 5-minute screening. And then those who did not activate their membership had one visit, about an hour, where we asked all the questions over the phone, whether it be quantitative or qualitative. Everything was done over the phone by voice and audio. And if they were responders, they had more questions that we had because they actually visited the wellness center. There was more detailed information that we wanted about that experience. So we split their visits up into two 45-minute visits. The first one was going through the questionnaires over the phone. And the second one was an interview, a semi-structured interview that just focused on their particular experience. So as I mentioned, we use the socio-ecological model to really look at facilitators and barriers. And so all of our what I'm calling quantitative questionnaires are sort of listed here. I encourage you to go to the paper to read more about those particular questionnaires, but I just wanted you to see that we were really trying to focus on the different levels of the socio-ecological model and capture as much information as we could without overburdening the participants. Our qualitative interview, again, was semi-structured. We sort of focused the interview guide on two different sort of themes. One was the exercise prescription. I'm calling it the experience. So what was it like to receive the exercise prescription from the healthcare provider? What was it like signing up? What was it like visiting the wellness center? And so it was kind of like from the time they got it to the time that they were utilizing it. We also asked a lot of questions about communication between the patient, the healthcare provider, and the wellness center. So a little bit about responder recruitment. This particular group of individuals, the ones who actually went to the wellness center and signed up, were actually very easy to reach. So we worked directly with the wellness center staff, and they keep track of everyone who signs up and how they sign up and why they sign up in their computer system. So we were able to get lists very quickly of who actually was eligible. We put posters and flyers up in the wellness center. We made phone calls, we sent mail, we sent email, and we knew exactly who we were targeting, and we were able to update the progress for each individual. So we could say, yes, they're interested, didn't get in touch with them, this person's in recruitment. And so a little bit about one of the challenges that we did have is about 15% had information that wasn't current or available. So we only looked at people who had exercise prescriptions within 6 months to a year, and either their phone number was no longer active or working, or the address was unknown or no longer current. So that person didn't necessarily live at that address. So whether we had incorrect information or that person no longer had a working phone or had to move is unknown. But 15% seemed much higher than we were expecting of returned mail and just unable to get in touch with people, but still able to get in touch with a lot of different members. So I sort of drew, let's see, I'm stuck here. There we go. I drew sort of a schematic. So here's me, the university researcher, and here's our community partner. We had a direct link to them, and they helped us get in touch with the research participants. This worked relatively well. We were able to get in touch with 250 people, and that made 30 participants who recruited and were willing to participate. So we were able to do that relatively fast. So that was a success. Now, non-responder recruitment was a little bit different. In order to get the people who got an exercise prescription but did not sign up, we had to work through the local community health center, because we needed to know from the medical record that they got the exercise prescription. And then, because electronic medical record is HIPAA protected, we couldn't access that information outright. We had to work through the community health center. So I have this schematic to show this convoluted group of arrows. Here's me, I'm working with the wellness center staff. They're putting me in touch with the community health center. And because of HIPAA, I can't directly link to the patients. So that made it super challenging, and it caused some delays. So we weren't able to directly access the information because of HIPAA. So in order to get the information, we had to ask a computer programmer to pull from the electronic medical records, and this request needed to come from the executive director. And in order for this to happen, we had to go through a special separate IRB process for the community health center in order to get approval to have this information. And all of that is reasonable. But one of the issues was once the report was actually generated, we couldn't actually check it because of HIPAA to know if we had the right data or the right information. So we just had to, trust that if we said we wanted these dates and these sorts of patients, that was what we were getting. So that made it challenging because of course you always want to double check everything. The other thing was the community health center would only allow us mailing addresses. So we couldn't follow up with phone calls or emails, which was a more active way of following up. We had to physically bring our letters and postcards to the health center They printed the labels for us and we had to affix the labels there. And then they physically mailed them to us. So we weren't actually able to hold on to any of the address information because of HIPAA, which is completely reasonable, but it made the process very passive. We could only mail. And so we mailed postcards and we mailed letters, but we didn't know what was getting sent back. We weren't able to follow up in any way. So it was super passive. All of these challenges resulted in a 6 to 8 month delay. And we sent out 500 letters and 500 postcards, and we got 5 people to respond and actually participate in the study. And so this was a lot of effort for very little return. And it was one of those shoulda, woulda, coulda, like, how can we do this differently next time? So if I could do it all over again, I would have started the non-responder recruitment much earlier. You know, hindsight is always 20/20. I would have developed a community engaged process with the community health center. So remember, my partner is actually the wellness center, the gym, not the community health center. But in order to get the information I needed to also partner with the community health center. And, you know, those priorities are different. I'm helping the wellness center. We're working on this project together, but the community health center has different priorities and different timelines. And so that didn't necessarily mesh as well as I wish that it could have. We definitely needed more internal support. So paying someone within the community health center as my computer programmer would have been something that we could have done. Paying an intern to do the mailing and affixing the labels and things like that would have helped some of the delays in getting our people there to do that work. So having more internal support within the community health center through funding was really something that I would do differently next time. So once we actually analyzed the data, I just wanted to share with you, we had been focusing all of our effort on Codman Square Health Center because they were down the street and they were the most referring health center to the wellness facility. But when we looked at the data, we actually had recruited people from 7 different health centers. So we had put all of our eggs in Codman Square Health Center, when in reality, we could have actually partnered with all these other health centers, done the same process, and recruited more non-responders, from a larger net, if you will. So next time I would not just partner with one community health center, I would partner with multiple. And that way we could cast a wider net and hopefully get more non-responders. I did want to just take a few minutes to talk about writing the manuscripts, because I think it's important when you're working in populations that are especially at risk to just have a clear perspective about who you're writing about, especially when you do community engaged research. So just to acknowledge the current social and political climate, I started this research in 2017, and I published this research in 2021. So if you think about the time and the things that changed during that time, considerable things were happening. And so I just wanted to sort of touch on Black Lives Matter, this huge shift for diversity, equity, and inclusion that was happening during that time. And so I just want to acknowledge that my perspective and my experience is very different from the people that were part of my study, as well as my community partners. And so it's important to just acknowledge that and make sure that everyone is on the same page with how you're displaying the information, how you're talking about the community, and using the right terminology, because terminology actually is a moving target. What was appropriate 5 years ago is not appropriate now. So in order to make sure that I was using acceptable language, I got support from my community partners. They actually engaged in the writing process. They helped edit my manuscript to make sure that I was saying things appropriately. I also had mentors who do work in similar communities across the US give me advice and suggestions. And then I want to give a shout out to the ACSM Leadership and Diversity Training Program, because I have several colleagues that participate in that. And I talked to some of those members to make sure that I was thinking about all the right things before, putting this paper in for review. So the important thing is always be willing to listen, be open, and be flexible, because something that you may have said previously may not be appropriate later on. So I'll give just a few examples of this. My original title was here. And I called the women minority urban women when I did my grant funding. And I sort of, like, when I was writing my manuscript, that like made me pause, and I was like, that's not appropriate. I can't say that. That's not the right terminology. And so terminology is super important. So in talking to my colleagues, the word urban, what I meant was it was happening in an urban setting. It was an urban exercise prescription program. And I didn't want to describe the women that way because that may have a negative connotation. So I made sure to use the word urban to describe the place or location and not the people involved. So that was a really important switch. The other thing is, Mark mentioned, I moved from Boston to California during the time that I was writing this paper. And when I was in Boston, I used the word minority to describe Black and Hispanic participants. But when I moved, California, that's not the right terminology. So I realized, depending on where you're coming from, that word has different meanings. So I needed to remove the term minority to make sure that I wasn't not representing the population correctly, depending on where you're coming from. And then finally, the words that are used in the literature. So when I was writing up the paper, you know, the papers that I was citing used words such as vulnerable, special, underrepresented, underserved, economically disadvantaged, and marginalized to represent the population that I was talking about. And some of these terms have negative connotations, and I wanted to make sure that I wasn't bringing that into my paper and that I was representing the women accurately. And so after much discussion with many of my collaborators, we decided to use the word under-resourced to refer to the lack of resources. And this is from a blog that I read that I just really resonated with. Use the phrase under-resourced as a more accurate way to frame larger issues. For this purpose, resources include leadership, physical assets, money, power, political will, institutions, community cohesion, and services. And this really kind of got at my socio-ecological model and looked at all the different levels of resources. And so I thought this was a better word to represent what I was trying to say about the community. So here is the original title. Here's what we published with. We used the word under-resourced, took out the word minority, and moved the word urban. So although that seems super subtle, it took a lot of discussion to come up with that. I'm not going to go over the results today, but I encourage you to read the full paper. You can feel free to ask me during the Q&A. I'm happy to entertain any of those questions. But I do want to point out some strengths and limitations. You know, we were really excited to use community engaged research methods, mixed methods, look at this situation in an urban location and under-resourced women. But because of the mixed methods, this obviously results in a small sample size. It takes a lot of intensive effort to do mixed methods. And because of that, you have small numbers. The response rate, as I mentioned, for the non-responders was super low. And so my publication didn't actually include any of that data because I didn't feel that it was, it didn't represent what I was trying to. So we had to leave that population out, and that will be a focus for some future studies for sure. And of course, this was only one wellness center, and so that's important to sort of keep in mind. I just want to acknowledge my collaborators. I mentioned there's a huge team of people that worked on this, and so I just want to thank them because it takes a lot of different expertise and efforts in order to get this work done, especially with multiple community partners. So I just want to say thank you to everyone. And thank you to all of you for listening. And of course, thank you to all the funding that I had to support this work. So I'll stop there, stop sharing, and I'm happy to take any questions.
Sarah, that was fantastic. I mean, I couldn't have scripted a better presentation for our needs. So thank you so much. And truthfully, I had no idea of the scope of the work you've done, and it was really quite fascinating. So I'll get the ball rolling with a question here. If you'd moved out from Boston to San Francisco, so that obviously makes continuing this work difficult. But if you'd stayed in Boston, what was the next step? You have like this really nice data set. You have this great pilot work, all this knowledge. What would you have expanded it? I mean, where does it go? Where would it have gone?
Well, I think the paper that I was able to publish really looked at the responders well. And I think those non-responders, the people who did not turn in their exercise prescriptions, that's still a big question mark to me. And that's definitely where I would go. And that takes a lot more work and effort, as I mentioned, than what we had originally planned. But by doing this work, it kind of highlighted how to start those partnerships and then how to do that work better next time. So I think, my research served as like a pilot for like how to start it, but it wasn't enough to get it going. And so if I were still in Boston, and I still have many collaborators there, so it's not to say we couldn't do this work, because I still have those community partners, even if I'm not physically there, I would definitely focus on the non-responders, because those are really the people you're trying to reach. Like, why aren't they turning it in? The other thing I'll just mention is, even though there was notice in the electronic medical record that an exercise prescription was given, there was no way for the wellness facility to get that information. So the only way the wellness center knew the patient had it was by physically turning in a piece of paper, which seems so old-fashioned. But that was something else that I had conversations with, was how do we refer out in the electronic medical record so that everyone is communicating? The wellness center gets that information. And so the wellness center can follow up with the people who got the exercise prescriptions to increase those non-responders. So that was something else that we had started to talk about, was how can we get people who are not responding to respond? So it's sort of like all those little nuances. Why do they have to bring a physical piece of paper? That seems like not the best way to do this. And so they were actively trying to figure that out as I was leaving and coming to San Francisco.
Yes, Sarah, that takes me back to a study I did before I was involved with EIM. We had a community-based wellness program, and we were trying to recruit. So we thought we'd just recruit patients from all the primary care centers around. And we had great enthusiasm from the clinicians, and we set them up with referral forms. At that time, we used a carbon copy, and so it wasn't HIPAA. They were just telling us who they gave a referral to. And we thought it would work so well, but we were really focused on the program, not the recruitment process. And then we weren't set up. And then when it didn't work, and we didn't even get the referrals, forget about the non-responders, we didn't even get the referrals. I just thought it was fascinating. And probably my biggest miss as a researcher, that we weren't prepared to look at why the clinicians weren't providing the referrals in the first place. And I wish I could always go back knowing what I do now and make that change. So your comments are bringing me back to that time and point. So, but this isn't about me. I'd like to hear what other questions people might have out there. So raise your hand or throw it in the chat room, please.
Well, let me do.
All right, TJ, jump in, please.
Okay, I was looking for the raise my hand. Great presentation. I really enjoyed it. And I have a question, and this came to mind, Mark, really after your last comment. And so when you talk about not really getting the referrals from the clinicians, Sarah, now I'm going back to you, Sarah. How can you take this approach with it being community-based, but faith-based, and getting the referrals in the hands of the faith-based leader, meaning they're not a clinician. So how are they credentialed to provide an exercise prescription, right? So how do we credential a faith-based leader? That's my question. So that they can give out those referrals, right? Exercise prescriptions to their community members to then participate in a program. Or help me think that through.
Well, I think, Mark, do you want to?
Oh, it's your webinar.
I don't know if I have all the answers to this, but I can start. So my understanding is, exercise prescriptions are not actual medication. So anyone can give an exercise prescription. You don't have to be credentialed, but of course, giving the right information is really important. So making sure that you're giving, evidence-based amounts and the right amounts is really important. Something that's, I know, challenging even for healthcare providers is how do I get someone started? So there is some training that is needed to give good exercise or physical activity prescriptions. I know that for people who are sort of outside of this space, you know, faith-based organizations are a wonderful connection for people to find some of these resources. And I know that there's some research going on looking at some of these partnerships, but I'm not as familiar with those studies. But I know that it just depends. So if the person who's leading a faith-based exercise program is someone in the exercise or physical activity realm, those people can get the training or give those particular prescriptions. And Exercises Medicine does have credentialing so that you can, you know, show that you have the skills and the expertise. I don't know if, Mark, do you want to, I know that's undergoing some changes right now, but there is actual certification that, or is it called credential? I don't want to say the wrong thing, Mark, that you can get to show that you have the expertise in order to sort of do this programming. And there's different levels so that it is indicative of your level of experience and expertise. Mark, do you want to add to that so that I'm not misstating anything?
Well, and I see Lori on here, and Lori and I, Witzel from American Heart Association, we wrote a paper, and really to clarify this, we look at things as in very general terms as referrers and receivers. And the receivers could be looked at as your exercise professionals, and your referrers might be your clinicians, but there's a lot of gray area in other people. So Sarah, the EIM credential is for the receivers, the exercise professionals in the field. TJ, I took your question to mean, how do we empower people to provide the referrers good exercise prescriptions? That's what I took you to mean. So you're speaking on the other side. Now, with that question is, I think we run into this problem of thinking that the referrers need to give an in-depth prescription. The referrers need to, in my opinion, need to get patients to the resources, to the community wellness center. The experts are there that can then come up with the program, whether it's your students or EIM credentialed exercise professionals or whatever. Sometimes, and I see this across the world, we spend a lot of time thinking that we need to train the clinicians and the doctors and the nurses to be exercise experts. No, I think they need to be trained on the basics so they feel confident to have a conversation, identify contraindications, and then hand them off to an extension of the healthcare team. And that's kind of what we're looking at. So that's how I approach it. So if we're looking at faith-based, you know, could we do in-service training for 30 minutes, an hour and a half to give them the basics, to identify people that shouldn't be going to an exercise professional, maybe getting a checkup instead from a doctor, and then referring people on for that care. The challenge with all of this, and Sarah, you talked about, is how do we capture this data-wise as part of research? Because it's very complicated. You know, a person refers on 100 people. Do we capture that? Who goes, who doesn't go? Why do they go? Why don't they go? So not only is it difficult thinking through how to do it, but then you think through from a research standpoint, how do we capture that variability and the reasons for it? So EIM research is not easy to do. I think, Sarah, was your main point today, wasn't it?
Yeah, hopefully that came across. Took much longer than expected, and then you learn a lot of things along the way, and you end up with all this data that you didn't do anything with. So, I have all this data from the healthcare providers and the health center, and that wasn't my original research question. That was just my preparation, but it's still rich data that is still, interesting, but it's, you have all this data. What do you do with it?
We look for PhD students.
Yeah, exactly.
TJ, did we answer your question?
You did. Thank you.
Welcome. Anybody else? So Sarah, I love this topic. I can talk all day. Let me ask you, let's talk hypothetical, and this might be the situation of people on the call. You happen to come across a system that was kind of already running. right? You had this wellness center that was accepting and giving free memberships and encouraging referrals. But if you didn't have that, do you think you would have been able to do the study? And if that didn't exist, would you even got into this area? So can you comment on that line of thought?
Well, that's a good question. So I think for me, it wasn't like I approached them and said, let's do research. It really came out of conversations of working with these particular individuals for it was like 4 or 5 years that we had been working together. And then I kept hearing comments like, well, we don't know this, we don't know that. And so the research came out of conversations of them getting to know me, getting to know what my interests were. So that's really where the research was born. It was not me approaching them. It was them revealing to me their frustrations and their questions. And so if they didn't have the program, I don't know that this research would have ever happened, because it wasn't my idea. It was their idea. And that's kind of the essence of community engaged research. So I encourage you to be thinking about the fact that like research exists everywhere. It's a matter of kind of positioning yourself, gaining the trust, having conversations, networking, and those ideas come from those conversations. So, it was just one of those things that it took a very long time for the question to even come on the table, and you have to be patient, right? I had been partnering with this organization for like 5 years before we even talked about research. And that was partly purposeful because you never want to push yourself as a researcher. But also I wanted to make sure that we were doing something together that was meaningful, because that's how research gets done and is successful. So you see there's a question from Lindsay. Was there data collected on mothers versus women without children? Yeah, we actually collected information on whether women were married or single, also how many children that they had and how many dependents were in the household. So that's all in the paper. And we did find that women with more children and who were single were more likely to not participate. So, so there was some data to sort of suggest that. And again, that the data that I'm quoting is the non-responders, so that the data that was not published. So it's just data that I know offhand.
Sarah, I think we have time for one more question here. Jackie has a question.
So she's asking, I'm curious if the community engaged approach led to recommendations on the exercise prescription itself. Yeah, so I actually, I gave the results to the community partner, and at that time I was also transitioning to come here. So it was actually more difficult than I was expecting to reach back out to the partners and give them the recommendations, but they do have them. So the idea is that they have the information to think about how they want to use that information, to change their exercise prescription program. So one of the things that I'll just sort of point out was the exercise prescription gave them access. It did not give them programming, and there's a difference. So access means you get through the door. Programming means you have someone there to actually walk you through, orient you, so on and so forth. So this nonprofit wellness facility, sometimes they were able to offer orientations and some measurements at baseline, and sometimes they weren't. It depended on their funding and their staffing. So it was a bit inconsistent. It also depended on if my students were volunteering or not as part of the community engaged learning component. So access is one thing, programming is another. And so there wasn't a lot that we could say about the programming and exactly what they were doing once they walked through the door, because that was very inconsistent and not necessarily like a structured entity that we could evaluate, if that makes sense. So we gave them mostly recommendations on, what the women were like, what was getting them there and what was keeping them from coming, so that they had that information.
Well, Sarah, this has really been an amazing, fantastic webinar. Thank you so much for sharing this with us. great audience today. We'll put this on the website so people can, view an archived version. We're having a number of events we're starting to put together for January, February, March. We're going to have a great schedule. I promise everyone we'll have communications out by early January on that. There are no events scheduled for December for the RLC. So I want to wish everyone a happy Thanksgiving and holiday season. And Sarah, again, thank you so much for joining us. Okay.
Yeah, thanks for the invitation and thanks all for coming. I hope my experiences help you. So feel free to reach out in case you have any questions.
All right. Take care, everyone. Thank you.